start the event off.
Thank you so much, Donna, for that wonderful introduction as always. So good evening, friends, and really good to have your company on this really sunny evening. We have covered enormous range of topics throughout our health equality series, including some so-called taboo issues or things that people don't often talk about. But I don't think we have ever had something that's quite as emotive as issue of GP access. After all, being able to get a GP appointment when we need one is something that affects all of us. More than that, our 75-year relationship with our doctor is one of the things that sits at the heart of our experience with our beloved NHS. Many of you will be aware of the pressures that GP services are facing and the knock-on effect this has had on patients being able to get an appointment when they need one. Recently, the North West London Integrated Care System started talking about changing the way we access GP appointments with the proposed introduction of same-day access hubs. Those who came to my scrutiny committee last month will have seen just how divisive this proposal has been and how much more needs to be done to ensure residents are brought into conversation about GP access, as well as indeed the GPs themselves. So I'm delighted to be hosting one of these conversations here this evening. And with me to discuss the issue is the incredible Dr. John Lister. With a background in journalism and expert knowledge of our country's health system, John has been one of the loudest voices in the fight against NHS cuts and privatization. I'm delighted that he's been able to find some time from his busy schedule and join us today to talk about our health service changing and what needs to happen to keep patients at the forefront. I'm also looking forward to hearing what you have to say about this issue. So there will be lots of time for your questions and indeed comments too. But first to John. John, really thank you so much for joining us. We are all excited, I'm sure, to hear your overview, please. So over to you, John.
Thanks so much, Ketan. It's rather hard to live up to that already, but I'd just like to stress that I'm a doctor, PhD doctor, doctor of health policy, not a medical doctor, just in case there's any confusion there. Yes, and the system that we're here to discuss, the proposed changes, very substantial changes to GP services, so that people wanting to speak to a doctor the same day would be processed through hubs. Now, there's 45 primary care networks across Northwest London, and it's not clear. In some cases, those networks would have a hub each, and in other cases, several networks would be joined together, so quite large areas would be covered by a single hub. But the hubs would be staffed primarily not by GPs, and the calls from the call handler would in large measure not go to GPs. This was the model that was actually published eventually by North West London after the information leaked out, and only because the information had leaked out, that they had planned to actually roll this system out from the 1st of April. Now, you know, it's quite remarkable that unelected NHS leaders can choose to think it's correct to actually roll out very substantial changes like this to primary care, which means so much to so many people, without any consultation whatsoever with the GPs themselves, without any consultation with the public who actually were going to be receiving this service, to explain the merits, explain how it might work, and justify the changes that they're making. No attempt to do that whatsoever. Had this not been leaked out to the media and become a cause célèbre and taken up by local campaigners and of course by angry GPs challenging these proposals, they would have tried to actually roll this out by April the 1st, in a matter of 6 or 8 weeks from the time that the information actually leaked out. So I think this is the first point. And it's interesting that it appears now that the North West London Integrated Care Board is now saying, oh, well, we're promised that the new proposals would be delivered through a process of co-production. Well, if I have co-production, you have to have engagement with all of the relevant parties. And there's no sign whatsoever that they're prepared or interested in actually engaging with that. Instead, just a week or so ago, a few days ago, we had threats issued by the North West London ICB that actually GPs should not be speaking out on this issue on social media, should not be raising issues which might alarm patients. And there's an incredible statement from Dr. Genevieve Small, who appears to have emerged as one of the primary care medical director in North West London. And she says, for me, the thing that's actually keeping me awake at night is that we've made our patients incredibly anxious. Now, she's trying to suggest that we, in this case, it's her and all the GPs who have actually raised challenges to the proposal that she has put forward. We have made patients incredibly anxious, and they felt that general practice as they know it is ending on the 1st of April, and they won't be able to see their GP anymore. Well, who made that? Who created that fear in their minds? But North West London ICB with the proposals and the way in which they proceeded to try to implement them. If they want to settle the minds of patients and assure them that their GP services are safe, their first step was surely to scrap this scheme and start a proper process of engagement on how they want to develop and improve GP services in the area, involving the GPs and including those GPs who currently deliver same-day GP service access already without any of these changes being made. And try to convince people that this really is an improvement and convince the GPs themselves. That's not what's happened up to now. As I say, the model that was actually given and sent out by the North West London ICB to explain their proposals was that they give it in numbers. I've worked it through in percentages, so it's easier to understand. That of the calls coming into each hub, 93% would be handled by staff other than GPs. This would be sent to, for example, physician associates, other additional role staff, pharmacists, all kinds of people, some of whom may or may not have useful things to say, but none of whom will be the appointment I think most patients would be expecting to be given, and the person they'd be expected to speak to. Just 7% would be handled directly by a GP from those initial calls. Now, this is a very substantial change, and you would expect some very substantial argument to back it up and to show how it can actually in some way contribute to an improvement in patient care. Sadly, we've seen none of that argument put forward. We've been told that this has been trialled in 10 primary care networks in North West London. None of the findings of those 10 pilot projects have been published. And it appears that none of them have been collated or are in the position to be published. It appears, in fact, the pilot projects were simply a first stab at implementing it rather than a serious attempt to evaluate whether or not it worked and whether or not it was acceptable to GPs. And it's quite astounding. Why run a pilot project if you're not going to evaluate what the results were before you roll it out on a wider basis? This is a completely ridiculous way of working. And there's been no plan at all, and there still is no plan at all to consult with patients or properly with GPs as a whole on the way forward on this. The North West London Chief Executive Rob Hurd says no consultation is possible because it's a national plan. It's being imposed nationally by NHS England. But if it's a national plan, why is only North West London actually doing this? There's nowhere else at this stage and in this predicament that's been created by the way they've handled it. Oxfordshire is being handled very differently. There are still arguments going on about changes and proposals in Oxfordshire, but it's been done very differently, and the extent of GP involvement is much greater in the handling of calls. And so it seems that North West London is actually being used as a guinea pig, and national decisions are being used as an excuse. It's a claim that the plans were all agreed years ago. There's no evidence that GPs have been engaged in this process. Sorry, that's our front door. I won't be going to answer it. Somebody else can sort that out. There's no evidence of GPs have been involved in the process, no evidence of serious discussion going beyond a handful of people at the ICB about this plan that they've developed. The claim is that the new proposals are centred on a national drive to increase same-day access. Now, this raises two questions. Firstly, have you ever met anybody demanding same-day access to somebody other than a GP? Have you ever demanded, I demand to see a physician associate today? Nobody does that. Nobody wants that. They want to see GPs, they want to see GPs more quickly. And we can understand that. And in some areas, of course, in Northwest London and elsewhere, GPs have been able to do that and been able to develop systems to deliver that. But if you're saying you can have same-day access to somebody other than a GP, that's not necessarily answering the question that patients are asking. And secondly, if same-day access is the aim, why not start indeed by talking to those GPs in Northwest London who are already delivering it about how they can work it and what resources they're using, and roll out similar systems and back up those systems for other GPs across Northwest London. The argument is the new plan would give a single point of triage in each primary care network, so you could actually separate out the less serious from the more serious cases. Now, if you're going to triage patients, if you're going to do that separation, you're going to have to make clinical judgments. You should have the most advanced and expert clinical people doing that work, not people such as physician associates who have just come through a 2-year master's course from a general science degree. These are not people equipped to make those type of decisions. They should be referring all of them to a GP who will then decide who could be followed up by other categories of staff and in what role they could play in their treatment. The focus on same-day access is linked to the claim that if you improve same-day access in GP services, you can actually reduce the pressure on accident emergency services. Fewer people will be going to hospitals, and therefore it will be contributing to lessening the pressures on the rest of the NHS. But all the evidence shows that if you use less qualified non-doctors, less qualified staff to see patients in urgent circumstances, they're more likely to send them to hospital, they're more likely to demand more tests, they're more likely to put more strain on the secondary care services than if you actually employ GPs in the first place. We're told that Northwest London is following what the Fuller stocktake. It's a report by a woman called Fuller, who produced a series of proposals in 2022 for reorganising GP services. Now, there's a big question there about to what extent that's ever been properly consulted on and discussed and agreed by GPs and those required to actually implement these services. And nobody's actually come up with any answers on that. It appears to have just been published by NHS England as a new diktat, and nobody appears to be willing to actually answer questions on it or respond to it. But if this is a national policy, why is only Northwest London doing it? Why is the rest of the country stood back and we're watching to see what happens in Northwest London? In fact, we've had NHS England saying that they're standing back and allowing local areas to do their thing. They're not actually laying down the law at all. It's only in Northwest London we're being fed this line that actually this is all coming at national level and all we can do is comply with it and carry out orders as we're told. Northwest London ICB says there is no need for any consultation. But I would submit that actually switching from a previous system, which is well understood and well liked, to a new system that's highly controversial, that would drastically change the GP's role and the relationship with patients, and which raises safety concerns, which GPs have raised and the local medical committees have raised, is a serious change. And that does specifically require a consultation with the GPs themselves, with the staff working in primary care, and with patients and the wider public about the implications. It does require that, and there's no good argument why they've not done that and they're still not planning to do that. The ICB now say they're asking the primary care networks, and this is their quote, to work with patients and residents to develop proposals. Well, are they? Do they want any proposals? No, they just want to find ways in which they can bore people stupid enough to actually allow them to push through their original plan intact. That's what they're trying to do, drag it out long enough so more people lose interest and allow them to just get away with what they're trying to do. So that appears to be what they're doing. There's no sign at all they want any new proposals, any constructive proposals to come forward from the GPs on how best to actually approach this question. So this is a test of the extent to which there is any genuine accountability and any genuine responsiveness of the local NHS in the new setup of integrated care boards to the local population, the communities that they serve. Are they simply going to be able to ride roughshod and impose these things, despite the fact that integrated care boards are supposed to be much more integrated with local government, with social care, with wider and local community forces, and paying attention to their needs and their wishes. And finally, we have to recognise that the plan touches on the highly controversial expansion of numbers of physician associates. This is a new category of clinical staff with a very limited clinical training, just 2 years of clinical training, 1,600 hours of patient and frontline exposure to services, and a master's degree in which they only need to go as far as a postgraduate diploma, not the full master's. So these are people with clearly a commitment to delivering some form of healthcare. These people are paid, in some cases, up to £12,500 a year in fees, or some cases even more in fees, plus all the other costs of 2 years full-time education. These are not people we want to just dismiss, that they've got no role and they can play no useful role. But clearly they're not in a position to actually do what experienced GPs have been doing after all the years of training and background that they've got in the job. To simply say that physicians associates can actually be brought in and effectively slot into running a part of what was the GP's role is not proven, and it's not a sound approach. And the reason why the NHS in Northwest London in particular and elsewhere has been so keen to promote the role of these physician associates in primary care is because if they employ these people and put them in control of undifferentiated calls from the public, they can actually claim the cost of their care, of their employment, from a special fund. So in fact, effectively, these are free staff. So not only are they cheaper to employ than GPs, but they're actually almost free in the sense that up to £53,000 per person per year can be funded directly from the Department of Health. So there's a big financial incentive to drive through these changes, whether we like it or not. And of course, at the same time, we've got the bizarre situation where GPs up and down the country, locum GPs, are finding it difficult to get shifts because the roles are being filled up by these physician associates instead. Now, this is an ongoing debate, and it's not absolutely central to the Northwest London situation, except that it's similar type of new clinicians are being brought into these additional roles. And there are, I think it's 15 different additional roles that are funded under this scheme. And this is the underlying agenda, I think, that we have to accept. They're saying if this isn't rolled out in Northwest London, they will lose the access to some of this funding. Now we have to say, look, the funding's only any good if it's going to improve GP services, and it's going to put GPs fully in charge of the services so that we can improve the services for all the patients that actually need them. If you're just going to take funding in order to undermine services and leave us with something worse, then I think we're better off without it. And I think that should be said firmly to them. And just finally, the research that has been done undermines all of the arguments for the actual use of these non-physicians to actually carry out these important roles, and the substitution of GP practice dealing with their patient caseload with these hubs. The plan rests on the idea that the staff are cheaper to employ than GPs, that their costs are covered by the additional funding, but that they are also going to improve the situation for patients. The research that's been done by the NHS and other bodies shows that using physicians associates and the other additional roles does not improve patient satisfaction, does not improve GP morale. In fact, they wind up having to supervise people for whom they can't possibly properly oversee the work they're doing. It does not reduce attendance, it actually increases attendances at accident and emergency departments. And it doesn't save money overall, because you wind up having to employ more GPs to actually do supervisory work rather than delivering hands-on clinical care. In short, none of these arguments hold water. So we're given a plan that's not based on evidence, has not been consulted upon, is opposed by the local medical committees and the GPs in the area, is challenged by campaigners and by many members of the public in the and politicians in the area, and is being tested in North West London before it's being tried out anywhere else. I think it's an outrageous attack on general practice in North West London, and I do hope that we'll be able to prove them wrong when they think they can just bore people into submission and eventually force this scheme through in 6 months, 8 months, 9 months, or a year's time. I think we need to be ready for them when they try and do that and make sure that this doesn't pass in North West London in the way they're proposing to do it.
John, thank you very much indeed. A lot of people clapping for that very insightful overview. Grateful to you indeed. So, as I said at the outset, friends, I am really keen to have your contribution this evening to this really important conversation. And I can see a lot of familiar faces, and I'm going to bring as many individuals as I possibly can. It's a delight to have my friend Meryl, who was at my committee, which I just referenced in my opening remarks. Meryl, really good to have your company, and thank you very much for all the fantastic work that you do in community. So I'll take Meryl, and my very dear friend Tony is also with us. And Tony, again, thank you very much for all the work that you are doing in community. But let me come to Meryl first, and then I'll come to Tony. Meryl first.
Thanks, Ketan, and thanks for those kind words. I will try to be brief. I will not say as much as I could say, and of course, John has said a lot that I would say anyway. The first thing, I'm secretary of Hammersmith and Fulham Save Our NHS, and have been campaigning ever since a GP, I believe in Brent, leaked the first news of this to campaigners initially in Brent, but we all talked together, we campaigners, and we learnt about this at the end of January, beginning of February. Of course, it's never been properly announced to patients and residents across North West London, let alone explained in full detail. And I think, given that there are a lot of residents and patients in this meeting, that we ought to be aware of that. We are still being blocked out of it, including from ICB meetings where it has never fully been discussed in a board meeting. John talked about the ICB talking about doctors being in trouble for mentioning this and talking about it publicly because it was making patients anxious. I want to suggest that what it's doing is making patients angry. I think that's much more important than it's making patients anxious. At least the patients I'm talking to are more angry about how we're being treated in this, how we're not being involved in this, and how the plans are being devised behind our backs as if we don't matter. Looking at my notes here, I have met with and meet with frequently ICB leaders, as do other campaign leaders. And as John has suggested, getting any responses and answers from them that are straight is virtually impossible. They're always ambiguous, unhelpful. We're told one thing one time, and then later on we hear something else, or we hear that actually the proposals are not for hubs, that we can talk about access generally, while at the same time we discover that emails and messages are being sent to GPs saying that they are about hubs, but they're being put off for 12 months before they're implemented, so that no one knows exactly anymore what is being presented and when it is to happen. And even just before the last board meeting, we had a meeting with the chair and the CEO of the ICB and tried to get clarification on these issues. And again, we were told, well, it's in the board papers. It was about 2 pages of a summary. And when I pointed out that the timetable there didn't make any sense, and it didn't say what was happening when and how the public would be involved, there was no information, and nor was any information forthcoming on how the public or patients would actually be involved in this process that they were promising we would be involved in. Another major issue is evidence. John touched on this. There's no evidence that's been presented at any stage that same-day access is an issue. We are told that access is a problem. And I think a lot of us would say, even since before COVID, but certainly over COVID, that we know that access is a problem. But access is a broad concept. And they've not yet produced any evidence that says same-day access is a problem. In the Health Service Journal, in fact, there is evidence presented that North West London, compared to many other areas, has overall good access, and indeed the best in London. But also, as I discovered only last week, NHS England has data on access because GPs are required monthly to present to the NHS access data. How long patients have to wait to get an appointment after they contact the practice. Why on earth has the ICB not presented that evidence in its papers saying that access is a problem? Even more, given that data includes same-day access, why is it not presenting the data that says same-day access is the problem? I don't believe it is. At my own patient participation group last week, we focused on access. And what came up? No one mentioned same-day access. What they mentioned was they'd prefer face-to-face GP appointments rather than telephone appointments. And it was pointed out, actually, most appointments are face-to-face these days. And some people raised the issue of the difficulties of using patches, which is the online access tool. None of those have to do with same-day access or the need for hubs. They are a different issue and require a different approach from what the ICB is taking up. So I think that we need to keep challenging the ICB about just what it is they think that they are dealing with. They need to talk to patients so that the problems that they are trying to deal with are the real issues, and not the ones that they are make-believing about. For what purpose, I still find it hard to understand unless there's some sort of money that comes with this that they're not being explicit about. Sorry to take so long, but I think it's really important.
Thank you very much. Thank you very much indeed, Meryl, for that. And indeed, again, for all the work that you, James, we have Andrew with us this evening as well. Unfortunately, Robin Sharp is engaged elsewhere, but a lot of you colleagues have been doing some amazing work. So hats off to you for leading on this particular conversation. Got a lot of hands up. So let me just take my friend Tony. and then I'll come to Jonathan, and then Peter, and then Faye. So Tony, over to you, please.
Thank you very much, Ketan, and thank you very much, John. I was on the steering group at the last administration when we were looking at GP access, and I think that was during the COVID period. And you know, this issue was a perennial problem in the sense that people couldn't actually get appointments with their GPs, and the excuse was that, you know, because of COVID, they had to limit access to the GP for health reason, and they started this implementation of telephone consultation, and I just think that really was supposed to be just for the period of the COVID period when everybody was afraid about, you know, contacting or catching COVID. That since has gone, and I think one of the issues now is, you know, this, you know, John has given a very compelling argument against what I would call this experiment in Northwest London, and I'm just wondering whether, given where we are, the fact that we are being used as a guinea pig, whether we can actually protest against, you know, this experiment that I would call it, and say, look, it's not working. Is this experiment because you want to save money? Is this experiment because there are a lack of GPs? You know, whatever the reasons, the fact is it's going to impact on people's individual health. And therefore, this experiment doesn't work. And we will want a reversal whereby we can have access to GPs if it means training more GPs, so that people can have access. But this experiment, as I call it, simply doesn't work. And maybe John can enlighten me enlighten us in terms of how we can reverse this experiment. Thank you
very much indeed for that contribution, Tony. And I think, Tony makes a much more broader point as well, doesn't he? Continuity of care, in fact. John, what are your thoughts, please?
Well, I mean, telephone consultations with GPs is certainly my GPs do it all the time. And the first contact you have with a GP is by the telephone. And in other words, you make the call to the receptionists in the department, the call handlers. They ascertain why you want to speak to a GP, give you say the GP will be in touch. They ring you, and if they want to see you, they call you in, and you actually see them face to face. 9 times out of 10, it's not necessary. There's something we can actually discuss on the phone, and I'm happy and they're happy that that doesn't happen. As far as that happens in my practice all the time, and I don't think there's an issue with that. And if you combine telephone and face to face, very large numbers of consultations already across the country, actually, not just in Northwest London, are taking place on same day anyway. There are a few areas where GP provision is very poor, but it's not at all clear that actually this type of system would remedy that, because it's a shortage of GPs we're talking about. And if you want to remedy a shortage of GPs, the last thing you do is start slotting in a load of people you employ instead of GPs, which is actually what this seems to be about. And just the pilot studies, I think it's really interesting. Where is the evidence on these pilot studies? If they've been a success, why aren't they telling us what a fantastic success they've been? Why aren't we getting the GPs coming along and telling us it's marvelous, it works so much better? Why aren't patients being rolled along to tell us how brilliant it is? I think the reason is they haven't worked very well, and they don't want that information to be used by people who are opposed to these proposals. And so they've just decided to put a lid on the whole pilot scheme exercise altogether. That's why it's this astonishing silence, isn't it? You'd expect if they had any evidence at all, it really worked, they'd be banging us around the head with it all the time, and there's just nothing there. So I think this is a bluff from their point of view to try to push these things through. And I just come back to Tony. Tony says, well, why is it being done? And I come back to, there is a financial thing here. There is a financial thing. They get funding to employ these additional role staff, including physicians associates, only if these people are employed in a role which involves taking undifferentiated calls from the public. So in other words, they have to be the first line responders to get the money. So NHS England has made that stipulation. That's the condition on which they can have the money. So this is a financial thing. It is being pushed through with that in mind. And I don't think we ought to let them forget it, that we know it either, because, you know, this is not an abstract discussion about how to organise GP practices. This is an abstract discussion about the extent to which we're going to have non-GPs running a core GP work in order to save a few quid from the budget of the ICB. And that I think is you know, really spells out exactly why we shouldn't be having anything to do with it.
Thank you, John, for that. So we are almost 2/3 through our hour, and I always say, don't I, every single month, that 1 hour is never enough. And this is a classic example where 1 hour is never going to be enough. But I'm going to take as many contributions as I possibly can, and I would ask you to be as brief as you possibly can, so we can get as many contributions in the remaining time that we have. And of course, we will try and ask John to come back in 2 or 3 months' time, and perhaps we can have part 2. I know a lot of colleagues who are engaged elsewhere have not been able to join us. And hopefully those colleagues can also join us when we have our part 2. So let me now move swiftly to Jonathan. Really good to see you, Jonathan. Your point, please.
Thank you very much, Ketan, and thank you for organizing the meeting. And John, thank you for that demolition of this project, this proposed project. It really has nothing going for it and a whole lot against it. I'm a retired GP. I didn't work in Brent or Harrow. I worked in Westminster for 25 years. And so many of the issues here are close to my heart. And I thought I would just share briefly my experience of this issue. Access was always a problem in that as a GP, you feel pressurized to see as many patients as you can and meet their expectations to be seen as quickly and as efficiently as possible. Because of funding cuts and the constraints in the system, it was always a juggling act. So we tried a whole range of different models for access. And, you know, my conclusion after 25 years as a GP was there is no one model that fits all sizes or is the perfect solution. So we tried a whole range of things. The thing that worries me most as a clinician is the de-skilling of the triage role. As John quite rightly said, the person who needs to do the triaging, the sorting out of patients who present on the day with unfiltered problems, needs to be the most senior and experienced clinician. The literature is very clear on this, and we have seen in the media already with physician associates these disasters where well-meaning people, and I agree with John here, we mustn't say they're useless and get rid of them. They could be a valuable asset, but they have to be used in the right way. We've seen disasters where patients have died because they've missed signs of serious illness. Not only on safety grounds, but again, as John has said, on efficiency grounds. Me as a senior GP, after many years' experience, I know exactly where to send the patient after assessing them on the day. For an X-ray, to see the physio, to go and get bloods taken, a follow-up appointment, and so on. A less experienced clinician will not have that knowledge and will generate unnecessary tests and unnecessary appointments. The problem is they are trying to save money. This is all about money, people. But you remember they promised us 5,000 new GPs, this government? We haven't heard much about that for a very long time now. And this Physicians Associates and the same-day access is one way of reducing costs, claiming money from different pots so that the overall budget can be reduced. And I'm very concerned that the ICB model as a whole is part and parcel of the drive to privatization and to make cuts. John has made a whole range of other points which are really great. I just wanted to concentrate on those. And if I could, with your permission, Ketan, just make an announcement that in 10 days' time, on Sunday, the 12th of May, there's going to be a conference in Northwest London, a small conference on this issue and other health cuts and concerns. And if anybody's interested in coming along, please let me know. If it's all right with you, I can post my email address in the
Please
chat,
do.
and people can
Thank
get
you
in
very
touch.
much, Jonathan, for all those many years of looking after the residents in Westminster. Thank you very much indeed. We are grateful to you. Peter, thank you for waiting so patiently. I'll come to you, and then Faye, and then James. Peter, please. Again, we are almost going to be running out of time very, very shortly. So it'd be really good,
I'll be as
Peter,
quick as
to
I can.
have your brief point.
Right. Okay. Peter Lyons, I think I'm now in my 50th year of being a patient at James Wigg. So I've got some experience to that. I've also got a diagnosis of prostate cancer. So anything that isn't usual, I get extra worried about. So I rang up yesterday morning, 8:30, you're 20th in the queue. Oh. And so why not try our online system, which I did. And I got a phone call back 3 hours later, which I didn't think was bad. And we discussed, you have to go through a diagnostic set of screens about what's wrong with you. And they're quite detailed. And they can also give you opportunities of putting in photographs. And then I had this phone call, we discussed what was wrong with me. And I think I was, and then the message was, well, where were you last seen by a clinician? I said, well, I had a hormone injection 2 days ago at UCLH. So she said, look, I think the best thing is if I get them to ring you. 4 o'clock, I had the nurse from the UCLH to oncology department, gave me a call. Now, I think, well, if the system ain't broke, why fix it?
I think that we had a comment, Judge, very similar in the chat as well. I don't know if that was yours, Peter, but I did read similar comment in our chat. And thank you to everybody who are putting your comments, your contributions in chat. Please do continue with that. I promise you I am reading all of it. Thank you. And sorry, Peter, do finish your point. Thank you.
Right. And then just to finish, but why is this happening? Because bureaucrats have to find something to justify their existence. This is what is at the heart of it. It's not about saving money. It's about keeping themselves in a job.
Thank you very much indeed, Peter. Thank you for joining us and for your contribution. Faye, thank you for your patience and waiting. I'm going to bring you in now, and then James, then Sandra and Andrew. So Faye, your comment, please, or your question.
Hi, thank you so much, Seth, and thank you for the very well presented, rather concerning actually, overview of what this proposal entails. So thank you, John, and everybody's contribution. Seth, I'm really grateful you're part of the scrutiny board and everything else, because I think you can listen very attentively to our emotions and the groups that we're representing. And I have attended most of the meetings with Meryl and
thank you, Faye, for that very positive feedback.
Yeah. What I really would like to ask and concerns me is the health inequalities and the inequality within our communities. This is an added addition to the inequalities, as a lot of the patients aren't even aware this is happening. My alarm is that some of the certain groups of smaller GPs I was led to understand, were feeling quite pressurized that if they were non-compliant to these proposals, they were going to be further penalized with removal of funds. This cannot be allowed to happen. Not only are they trivializing the needs of the patients, but this patient's physicians, the assistant that they've been promoting, they originally were trying to actually just force it through without consultation. And the way that they presented it, it actually was on Sky News, and I think that was rather relevant, which put a halt to it, that a patient, a young lady, had died because the parents were sent to a physician's assistant. And this is a good example where you don't know the patient, a similar symptom can provide a very serious outcome. And the patient had a clot and not antibiotics that was prescribed.
Faye,
so thanks for that.
Faye, no, if you forgive me, Faye, please forgive me. I'm going to ask you if you could finish here, because there are lots of hands and I do want to bring all of those colleagues in. And I like always say at every single month that 1 hour is never enough. And this is a classic example where 1 hour was never going to be enough. But as I've said, this is, if you like, part one. I will try and persuade John to join me again in 2 or 3 months' time, and perhaps we can have a part two where we will have another conversation, if you like. So thank you very much, Faye. Thank you. Thank you, Faye.
Of the ICB, I think he needs to be here to hear firsthand.
Thank you. I will ensure that when I bring this item back to my committee, I will ensure that John is able to join, or try to get him online to join us. Very, very quickly reply to Faye's point, John, before I bring James in.
Well, I think the whole approach here is just ignoring many glaring issues of inequalities in access to primary care right across Northwest London, and obviously many of those linked to the poorest and most vulnerable communities and individuals who find it hardest. And you know, the statistics showing that the most vulnerable and poorest communities have the least provision of GP services already. Now, this is not going to solve that, because it's going to make it one step further away from it being able to rapidly access a GP for everybody, and including those in the most deprived areas. So I really think there is a big question of inequalities to be tackled by Northwest London. This is entirely the wrong way to go about it.
Thank you for that, John. We were hoping, as I said earlier, to be joined by Robin Sharp and my friend Anita Thakrar, but I think they are both not been able to join. So certainly I will discuss with John offline when we are able to have him back for part two. James, and then Sandra, and then Andrew. Andrew and Sandra, thank you for your patience. Let me bring James in.
Thank you very much, Ketan, for organising the meeting and for such an interesting meeting. One preliminary thing, it seems to me we're not going to get evidence. 10 years ago or so, we were told that Ealing Hospital as a major hospital and Charing Cross as major hospitals could be safely closed down. When evidence was asked for over 10 years, and it was over 10 years, no evidence whatever was given that you could close those hospitals safely. And some of the same people who appear online for the ICB appeared online for the North West London CCG, arguing you could close hospitals safely. COVID came, those hospitals saved lives. Briefly, I think key things are this. I think the public knows almost nothing about it. So for those of us on screen, one key thing is getting information out. A second thing is that one of the clear things which all the evidence seems to show is that patient safety hovers around the question of continuity of care, either with one doctor or with the trusted surgery, and this will go if the proposals are pushed through. There's a third aspect to this, which I think is actually quite important, and that is that doctors know it's unsafe, but they're working in a context where there's a general denigration of doctors by NHSE. They're being underfunded, they've got little in the budget, they're being told to put money into other services rather than to GPs. So what we need to be arguing for are better funding for GPs, more GPs. We need to be arguing in the context where all of us as Northwest London residents live, is that we need to get rid of barriers for people, particularly from the poorer communities, who are many in Northwest London, so people can see their GP face-to-face or by phone, but that triage is safely carried out by a trained diagnostician who later on may bring in a whole team of very helpful people. They're the key things I think we need to know, informing the public. I think, of these proposals would be a step forward to help sidelining what's been pushed on us. Thanks.
Thank you very much indeed. There are so many interesting comments in the chat. Unfortunately, not going to be able to take all of them this evening, but let me just take one. And Sudha, thank you very much for your many comments. Grateful to you. I'm keen to take a quick comment before I bring Sandra and Andrew in. Danny, you run a local charity, and you have put an interesting comment in the chat. And I just wonder if you want to just share that with us in case the colleagues on this Zoom call have missed it. Very, very briefly, please, Danny. Thank you. And good to have your company this evening, by the way.
Thank you. My worry is already stated, is about the vulnerable communities who are beginning to hear about this and ask us questions about what's going on. So, we have to do a lot of thinking about how we can support these people who are already under a lot of stress. And this is the last thing they need. And the key issue for them is they just want to access their GPs, whom they trust. Why do we need all these changes? We've got good surgeries, good GPs. We just want to be able to access them. And I think we can work together to resolve that. Thank you.
Perfect. Thank you very much. And Margaret McLennan, the former deputy leader of Brent Council, has put a fantastic comment in the chat, which I'm just reading. But before I finish reading that, let me bring Sandra. Sandra, thank you for your patience, and then I'll come to Andrew. And if we have time, then I'll take one or two comments from the chat, particularly Sudha, who has put many comments, and maybe Margaret as well. Sandra, please.
Thank you, Ketan. My question is, who will be employing these physician associates or clinicians? Is it going to be the GPs or will it be ICB?
Thank you. A very quick reply to that, John, please. Thank you, Sandra.
They'd be employed by the primary care networks, which are sort of over and above the GPs, but in between the GPs and the integrated care board. So again, the question of accountability is very questionable. The extent to which they would actually be accountable to the GPs, and who are supposed to be supervising them, who's supposed to be actually overseeing them on the basis on which they can practice. And of course, the ICBs sort of stand back and say, well, it's all being run by the local primary care network, which again is not a public body. And so I think all of that is really, really highly suspect.
Thank you for that. And Sandra, thank you for various comments that you have put in chat. Grateful to you. Andrew, you're another friend who's been doing some amazing work in the community. So let me also thank you and pay a tribute to all those amazing work. A brief comment would be very much appreciated, please, Andrew. Thank you.
Thank you for that. Yes, I wanted to say that in principle, I agree with the same-day access hubs, but I would like to decide whether I attend the hub. I think probably for 90% or 80% of my conditions, I could be seen at a hub. But I would like to decide that, or I want my GP to decide it. And I'm prepared to take one for the team and go down to the hub in Pimlico, if that frees up time for the GPs to see more complex cases, because I might be one of those more complex cases next time. But it's not so for everyone. For the disadvantaged community, and particularly for those that don't have English as a first language, they know their GPs, they know their surgery, they're not going to present at the other side of London with a team of people they don't know. They just won't go. So clearly it's not for them. And continuity of care is absolutely critical. Recent studies have shown that if you've known your GP for 2 years or longer, the chance of you dying in the next year is halved. It is that critical. Now, I think an experienced GP who knows their patients should be able to go through a list and very quickly triage these patients, decide whether they're a suitable case for the hub or not. But I think in principle, the hubs are okay, but we need to have the GPs who are signposting the patients to the hubs, or the patient himself. And if I get it wrong, I hope the hubs will send me back to my GP.
Thank you for that, Andrew. Grateful to you. Very, very quick. Sudha, do you want to just share your comment? And then Margaret. Thank you, Sudha.
Ask John what he thinks, what is the way forward? How can we tackle it in the interest of all patients?
Thank you. I don't know whether you can hear that, John, but I think the question is, what's the way forward? How do we ensure that there is due engagement with all of us?
Okay, so do you want somebody else to come in and then
Okay, I'll bring Margaret in. Margaret, your quick comment, and then I'll bring John to finish the event.
Yes, thank you very much, Ketan. John, as I say, I welcome your presentation today, most informative. For those in the room, I'm sure you'll remember that other huge strategy that was going to be imposed on us, shaping a healthier future. Again, there was much advocacy against it. We said it wouldn't work, GP said it wouldn't work. Of course, it didn't work and it was quietly put to bed. Northwest London was going to be the experiment because the adage is, if it works in Northwest London, it can work anywhere across the country. That is the adage that the NHS is moving forward with.
Thank you. And Margaret, thank you for all the amazing work that you're doing in the community as well. Thank you. Diana, did you want to very quickly come in? Diana Collymore, again, doing amazing work in the community. Very, very quickly, Diana. I don't know whether you can hear.
Yes, I can hear you. I just want to say very good. I'm very pleased that everyone has now got the opportunity to air their views and to let the NHS know that we're not going to sit back and allow this to happen, because our patients, our community matters, all lives matters. And, you know, as the what Dr. Lister has said makes so much sense. We have to work together, and we cannot allow any more decisions to be made behind closed doors, because people's lives matters, especially patients. Thank you, Chair.
Thank you. John, 30 seconds before I wrap this up, because we are almost at the end. And DNA expert, I don't think we'll have time to take your point. Maybe you can park your point or put it in the chat, and we'll pick it up and we'll bring you back the first time round in our part 2. John, please.
Okay, I think the way that shaping a healthier future was fought by politicians linking up with campaigners and building a broad coalition right across Northwest London. I think that's the model for fighting this. I think that's what's needed. Politicians, all the local bodies that are concerned in this need to actually mobilise their memberships and actually tell the individuals who are against this they're not alone. Nobody's alone in fighting this. This is a big movement. Actually, the vast majority of people in Northwest London, when they hear about this, will not be in favour of it. And I agree, it's not opposition to hubs as such. It's opposition to the way these hubs are proposed to be run. And that's exactly what we need to fight. And we need to fight for GP services to be GP-led and GP-controlled in Northwest London, as they should be across the rest of the country. These other additional staff to be brought in as proposed by the BMA within scope of what they are able to do and contribute.
Chair, may I just say, if we have another meeting, could we get Dr. Genevieve Small in the hot seat? And the second thing is, could we have more time for questions, please? We don't need people talking so much. We want question time. Would you not agree, Councillor?
Absolutely. As I've said to you, 1 hour was never going to be enough, and I have promised you 2 or 3 times already. I'll speak to John offline, and I'll agree a date with John, and we'll try and come back in 2 or 3 months' time. But let me now hand back to Donna. Donna, for your closing words, please. Thank you very much, everybody, and thank you for all the stuff that you have put in the chat as well. Thank you very much.
Will you invite
Donna, please?
I think Donna's having some technical issues, but if I can just jump in to say
thank you
so much to everybody.
For coming late.
It's all right. Thank you so much to everyone for being here this evening. And on behalf of the Health Watch services, just to say that we'll be taking all of these comments forward, and we really look forward to speaking again about these issues again in a few months' time. So thank you once again. Have a lovely evening. Good night, everybody.
Thank you very much. Thank you.